Look at this surge of electrical activity traveling up a nerve fiber. When a patient presents with chronic bloating, severe heartburn, or unpredictable bowel movements, standard clinical practice targets the gastrointestinal tract. But for conditions like irritable bowel syndrome and functional dyspepsia, isolated gastroenterological treatments frequently fail. The gut and the brain operate within a continuous, bidirectional neuroendocrine and immunological loop. Many psychiatric pathologies and gastrointestinal disorders share an underlying mechanical architecture, which explains why they so often appear together. Resolving treatment-resistant GI symptoms requires a diagnostic lens that can identify the specific central nervous system dysregulation driving the disorder. This approach views the gut and the brain's psychiatric state as components of a single, integrated system. The gut operates its own local processing center called the enteric nervous system, or ENS. This network contains hundreds of millions of neurons, earning it the title of the body's second brain. Its biochemical output rivals the central nervous system itself. The gut synthesizes 90 to 95% of the body's total serotonin, alongside heavy concentrations of GABA and dopamine. This diagram shows the primary physical bridge between that massive enteric network and the brain, the vagus nerve. Between 80 to 90% of signals along the vagus nerve are afferent, carrying data from the gut up into the brain, rather than the reverse. Because the physical data flows primarily upward, any chemical or microbial disruption in the intestinal tract immediately registers as a psychiatric data input. When the gut suffers from dysbiosis, an imbalance in its microbial composition, it generates systemic inflammation, marked by the release of specific interleukins like IL-1 beta and tumor necrosis factor alpha. This chart tracks tryptophan. Under normal conditions, tryptophan in the gut serves as the baseline metabolic precursor for central serotonin, following a healthy synthetic pathway. Under high systemic inflammation, tryptophan metabolism is rerouted. The synthetic process shifts away from serotonin and into the kynurenine pathway. This rerouting produces toxic kynurenines. These molecules are highly volatile, readily bypassing the protective mucosal barrier of the gut and flooding the bloodstream. Once in the blood, kynurenines cross the blood-brain barrier. They reach dormant microglial cells in the brain and trigger this aggressive activation response. This microglial activation actively suppresses brain-derived neurotrophic factor, or BDNF, which disrupts the brain's neuroplasticity. In this model, systemic gut inflammation chemically manufactures the symptoms of clinical depression, anxiety, and dysthenia from the bottom up, independent of psychological trauma. We can trace how top-down psychiatric states physically dictate gut failure. On the left, the anxiety phenotype. High anxiety drives hypersympathetic atonia. High corticoliberin and cortisol levels from the HPA axis cause the sympathetic nervous system to visually clamp down on the digestive tract. This sympathetic overdrive forces vagal withdrawal, dropping the parasympathetic tone required for calm, regulated digestion. This creates visceral hypersensitivity. The central nervous system misinterprets normal peristalsis as severe pain. Physically, this manifests as erratic spasms in the mucosal layer and a highly accelerated intestinal transit time. Clinically, this presents as irritable bowel syndrome with diarrhea, marked by sudden, unpredictable urgency. The sheer unpredictability of this urgency triggers secondary social anxiety. Patients begin avoiding public spaces out of fear of an episode they cannot control. Anxiety physically accelerates and hypersensitizes the gut, creating a self-fulfilling loop where abdominal spasms generate more panic, driving further HPA activation. Compare that to the depression phenotype on the right. Where anxiety accelerates the system, depression shuts it down. Depressive states are characterized by decreased central serotonergic signaling. This fails to stimulate the 5-HT3 and 5-HT4 receptors in the gut, causing the vagal signal to dim. This chemical deficit is compounded by hypodynamia, the lack of physical movement common in depressed patients. This leads to severe hypomotility. The bowel becomes physically sluggish and atonic. In the lower GI tract, this presents as treatment-resistant, constant, irritable bowel syndrome with constipation. In the upper GI tract, this presents as functional dyspepsia. Patients report early satiety, heavy distension, and a lack of appetite. notably without the sharp spasms seen in the anxiety profile. Depression functionally paralyzes the enteric nervous system. It requires therapies that restore motility rather than the antispasmodics used for anxiety. Standard GI therapies fail when they ignore these distinct central nervous system drivers. For the anxiety phenotype, the goal is to reduce central sensitization and suppress sympathetic overdrive. This matrix shows why tricyclic antidepressants, like amitriptyline, are used for this specific profile. The moderate anticholinergic side effects of TCAs serve as necessary spasmolytics for the hyperactive gut, physically slowing the rate of transit. Secondary options include gabapentinoids to dampen autonomic hyperexcitability and block the visceral pain signals that drive the anxiety loop. For anxiety-driven GI disorders, the sedative and anticholinergic side effects of these drugs are actually the primary mechanical therapy, but those same side effects are dangerous for the depression phenotype. High anticholinergic loads will worsen their existing constipation. For the hypomotility phenotype, clinicians utilize specific SSRIs to enhance central serotoninergic regulation. Restoring this serotonin cascade stimulates the dormant enteric receptors, physically restoring peristalsis. Achieving this often requires integrating psychiatric treatments, like mirtazapine, with direct GI prokinetics, like domperidone, to force the gut to restart. You cannot treat an anxiety-driven spasm with the same tool used for depression-driven paralysis. The anatomical separation of the human psyche and the gastrointestinal tract is a clinical illusion. Achieving remission in functional disorders requires treating the brain and gut as a single, indivisible organ system.